like to request Professor Mamunur Rashid sir to deliver his talk on where there is a will, there is a way.
Respected Chairperson, distinguished audience, Assalamu alaikum and very good afternoon. My title is Where There is a Will, There is a Way. Actually, during the intervention procedure, we think something that it will be done easily, but sometimes some difficulties arises during the procedure. And if we have strong will, then we can overcome it. This is my thinking. Mr. X, 58 years old male, diagnosed as a case of chronic coronary syndrome with hypertension and diabetes mellitus and having a history of non-STMI 6 months back. ECG shows T inversion in the V1 to 6 and echo was normal, ejection fraction was 56%. Angiographic view shows 100% stenosis from proximal LAD and retrograde from right coronary artery. We discussed about the case and decided to do it PCI to LAD electively. Then, contralateral view was taken to visualize the retrograde, and here it shows the retrograde from the right system. Trying to negotiate a wire in LAD with the support of microcatheter. At first we take the workhorse wire as run through, and later on we fail and we take the Fielder XT, and later on we take the Pilot 200, and we think that we cross the lesion and we are in the track, right track. But later on contralateral view shows that we are in the false track. Then after several attempts, we are in the right track and we got relieved. Then first we predilate 1.0 10 millimeter balloon, and then predilatation was done 1.5 10 millimeter balloon, which causes the dissection. We follow up the patient for 5 minutes and patient was hemodynamically stable. Then we proceed again. Trying to negotiate 2.0 balloon with the support of guide extension catheter, Godzilla, but failed. Then we thought what to do next. Then we decided to use the rotablator. Rotablation was done successfully with 1 millimeter bar at a speed of 4,000 to 6 RPM. View after rotab showing that antegrade flow was established, but it is not satisfactory. Flow is in the TIMI1 flow. Lesion preparation after rota with 2.0 millimeter balloon was done, which visualized whole vessel with TIMI2 flow. Then positioning of the and deployment of the distal stent 2.5 into 40 millimeter was done. Then positioning of the second stent, that is proximal stent, was done in epicranial view and iliacoidal view. Deployment of the proximal stent, that is 3.0 and 40 millimeter, was done. Post-dilatation was done with 3.5 and 15 NC balloon with the help of stent bush. Final result, without any major complication, we got a good final result. The patient was doing well. Proper planning and selection of appropriate hardware and advanced CTO-PCI techniques are very effective for success with few complications. Efforts needs to be focused on selecting patients most likely to be benefited from CTO-PCI. Several evidence shows CTO-PCI requires sound clinical judgment. So we should not hesitate to try for CTO-PCI when properly indicated. Just limitation is just in our mind. Thank you very much for patient sharing.